So today we'll be talking about maternal care and perpural sepsis. What's perperium? Perperium is the period following delivery up to 6 weeks postpartum. So it's the recovery phase after pregnancy, which will be the recovery of reproductive organs and return of physiology of the mother to the pre-pregnancy state. It's divided into first 24 hours for early complications and up to 7 days and up to 6 weeks, which there will be complete uterine involution and return of mens if the mother is not lactating. So the changes in the abdominal wall. The abdominal wall will be soft and poorly toned for many weeks. It will return to, the tone will return, but for it to be fully returned, it depends on the exercise. So we advise the patient to do exercises. The perineum will be swelled, engorged, and painful, but it will be gone for 1 to 2 weeks. Within 1 to 2 weeks. The uterus. The uterus will be shrink. There will be uterine involution from 1 kilogram to 100 to 200 gram. So immediately after the delivery, the fundus will be felt at the level of the umbilicus. 10 to 14 days after at the symphysis pubis, and 6 weeks it will be in a non-pregnant size. So the mechanism of the uterine involution. First, we have oxytocin, which causes contraction of the myometrium and causes vasoconstriction of the blood vessels, reduces bleeding, and shrinks the uterine muscle fibers. And we have autolysis of myometrial cells, which is due to a decrease in the progesterone and estrogen, drop in the estrogen and progesterone, and causes activation of proteolytic enzymes and shrinkage of the cells. Here, by autolysis, we don't mean death of the cells, just their size will be decreased. And also by decreased uteroplacental blood flow after placenta separation, there will be decreased blood flow and ischemia, and it triggers decidua, shedding of the decidua. Okay, so we have decidua. Decidua is a cast off of the decidua. And we have 2 layers of decidua, superficial and the basalis. The superficial decidua, which is the functional, due to ischemia and necrosis, it will be shedded and come out as lochia. The lochia will be, and the decidua will come out as lochia. What's lochia? Lochia contains blood, leukocytes, decidua, and organisms, which is a discharge, and it comes out as a discharge. So that was the superficial decidua. The basalis decidua, this decidua basalis, will regenerate and generate a new endometrium. Babinocerlochia. So lochia is a vaginal discharge along with decidua, clothes, membrane after delivery of placenta during perperium. It originates from body of uterus, cervix, and vagina, and it's fishy odor. First it's alkaline, then it's acidic at the end. So in the first few days, it's red, called lochia rubra. But as the bleeding decreases, it will be pink for the next week, and after the next week until the end of the second week, it will become white and then clears within 4 weeks of delivery. Also, the pinkish is called lochia serosa, and the whitish, which is the last one, is called lochia alba. That was about the lochia. Yes. And also we'll monitor for signs of infection. If the discharge smells foul smelling, it means infection and maybe endometritis. So we talked about the uterine involution. If this involution is delayed, fails, then it's called subinvolution. and the symptoms is the uterus will be soft and enlarged during examination, by manual examination, and we will have prolonged blockage, يعني more than 4 weeks, and also irregular bleeding or excessive bleeding even. And the causes may be either retention of placenta or infection. Also late postpartum hemorrhage can also be associated. This was subinvolution. So now we'll talk about urinary tract change. So during pregnancy, due to high progesterone, there will be smooth muscle relaxation. And also during labor, there will be trauma, edema around the bladder and urethra. And also, if there's anesthesia used, it will cause impaired bladder sensation. So all these can cause overdistension of the bladder, residual urine, increased capacity of the bladder and relative insensitivity, overdistension, incomplete emptying, and excessive residual urine. So this can cause increased urinary tract infection. And the dilated ureter and renal pelvis return to the pre-pregnancy state over 2 to 8 weeks after delivery. So this was the urinary tract. Now breast and lactation. And breast and lactation during the pregnancy, we have mammogenesis, which by increased estrogen and increased progesterone, there will be ductal growth and lobular-alveolar growth, and there will be milk production. But the milk is not excreted, it will be inhibited by progesterone, which blocks prolactin. Then we have lactogenesis, which is triggered by placenta removal. When the placenta is removed, there will be a sudden massive fall in progesterone. When there's massive fall in progesterone, so كزنية blocky prolactin يبقى, so there will be initiation of milk secretion. This is milk secretion. أو galactopoiesis. In galactopoiesis, it's controlled by prolactin, which is stimulated by suckling of the baby, and it maintains. The demand is, if there's demand, then there's supply. The supply depends on the demand. And if the milk is not removed, the feedback inhibitor of lactation accumulates and milk production will stop. So it's stimulated by suckling of the baby. Galactokinesis is removal of milk from the gland. When the baby is suckling, there will be a signal to the hypothalamus and posterior pituitary, and there will be release of oxytocin. And the oxytocin will cause contraction in the myoepithelial cells, and the milk will be ejected. This was the breast changes. The blood changes, hematological changes, there will be leukocytosis and thrombocytosis. Leukocytosis, as the labor is an inflammatory process, and also stress responses, all this cause leukocytosis. And thrombocytosis, as pregnancy is a hypercoagulable state, so the leukocyte count sometimes reaches 30,000. So and predominantly granulocytes. So here we will not depend, if we want to know if there's infection or not, will not depend on the number of the leukocytes. It will depend on fever, because it may be normal indeed to the labor process. And during the first few postpartum days, hemoglobin and hematocrit will fluctuate moderately, and by 1 week, blood volume will return to the non-pregnant level. So the blood volume with 1 week, but the cardiac output, it remains elevated for at least 48 hours after postpartum. But by 2 weeks, it will return to normal. So blood volume with 1 week, cardiac output by 2 weeks. And change of blood and coagulation factor, the coagulation factor change will persist for variable periods during the perperium. And so other physiological changes, we have increased thirst, constipation. Constipation may be due to pain, maybe episiotomylocraby, or episiotomy or hemorrhoid or maybe due to analgesics, opioid diabetes, and weight loss, 5 to 6 kilogram loss due to expulsion of the fetus placenta like blood. هم داره و پیشش جلوی کار کم دکا. 2 kilo during perperium due to diuresis and edema, decrease of edema and such things. And also gradual weight loss will be continuous up to 6 months. And menstruation will start after 6 to 8 weeks if the mother is not breastfeeding. After 6 to 8 weeks. And ovulation if the mother is not lactating 4 weeks. If lactating 10 weeks. And if the mother is giving exclusive breastfeeding, it will be 98% contraception up to 6 months. What's exclusive breastfeeding? يعني حتى شش ما نجيب بس شيرو خوي بداتا من ضالكي نشيرو قتينا أو نهي تشتك. So that will be 98% contraception. Abnormal perperium. Abnormal perperium will have fever or sepsis. Fever. Significance. Fever is not an automatic indicator of perpural infection. لأن بيشتر نخوشة هبوبي بيش childbirth okay نخوشة هبوبي. So it may not be due to the acute. It may not be an acute process. So however any fever within 10 days postpartum is aggressively investigated, but also there be investigation job pain. Physical symptoms as pain, malaise, loss of appetite, and others point to infection. So we have causes. What are the causes? The most common one is endometritis, day 2 to day 3. And then we have milk engorgement, mastitis, and breast abscess, day 7 to 21, UTI, day 1 to 2, and day 0 pneumonia and atelectasis, C-section, perineal wound infection, septic pelvic thrombophlebitis. Sequence of events استاوي لسر text بوشكة أو دكين باشترا. Yes. So here we have the day 1 to day 2. أقرب day بيلابين برز بندي. In day 1 to day 2, and this where we talk about we may have pneumonia or atelectasis due to maybe anesthetics. So if we have crackles on examination, it may be pneumonia or atelectasis. And day 1 to day 2, atelectasis, general anesthesia with incisional pain and smoking. I got smoker. Findings: fever, rails on auscultation, and patient unable to take deep breaths. Management is pulmonary exercises, deep breaths, and spirometry, and ambulation. No need for chest x-ray. Then day 1 to day 2, we have urinary tract infection, UTI. So the risk factors is intrapartum catheterization and multiple vaginal examination due to prolonged labor. We will have high fever, flank tenderness, urinalysis. We will have viable cell bacteria and also in culture. So the common pathogen is E. coli, and diagnosed by history examination, lab test, and the treatment will give antibiotic according to the culture, and single agent. Then day 2 to day 3, we have the most common one, which is endometritis. It's the primary cause of postpartum infection, and the risk factors, it may be an emergency C-section after prolonged rupture of membrane and prolonged labor. And the findings, it may be due to normal vaginal flora or enteric bacteria. The clinical findings, fever, uterine tenderness, and peritoneal signs should be absent and peristalsis should be present. So the key sign here is the uterine tenderness. And the risk factor: Gottman, C-section, prolonged labor, pre-existing infection, catheter, prolonged rupture membrane, multiple pregnancy, multiple vaginal examination, and due to prolonged labor, manual remove of placenta. Diagnosis أو ليرة GOTT, fever, chill, lower abdominal pain, vaginal bleeding, anorexia, malaise, or fever, tachycardia, fundal tenderness. This is the key point. We will have fundal tenderness. And the lab test CBC, ESR, blood culture, also infection, urinalysis, discharge and culture to exclude UTI, and pelvic ultrasound to exclude abscess, and clotting screen to assess for DIC. And they're not diagnosis for endometritis. And the treatment, later go TT amoxiclav lecture, but actually the most effective one is clindamycin plus gentamicin. Then the second option we have cephalosporin and metronidazole. Then the third option we have amoxiclav. أوش endometritis management تكا باس مانكر gentamicin clindamycin carbapenem microbial genital tract flora. Then day 4 to day 5 we have wound infection. Wound infection due to either the scar of the episiotomy or the scar of the C-section. So diagnosis is what تمشاون دكيدكين. There will be arrhythmia, induration, warmth, tenderness, and pus. La wound infection, the findings مثلا fever, wound arrhythmia, fluctuations, drainage. Management تكسيا يعني دو نوع معناه طبعا يا cellulitis يعنيش abscessa. كل زين cellulitis أجر أوبي pasi نبي أجر pasi يهبو أو abscessa. والبو treatment تكي فرق تكا. ولا أولش لا تبدرن abscess fluctuations معناها بس لا cellulitis نيتمان. So intravenous antibiotics. The cellulitis will give IV antibiotics that covers Staph aureus and streptococcus, anaerobes, and the rest treatment again. Okay. Wound drainage twice daily, wet to dry wound packing, dressing كده wet to dry بي لبو abscessi. And okay, suture knacking wound okay. It will be closed. It should be closed by secondary intention. بخوي قبعات بيتن. And يعني تكا أجر close بكين suture بكين the bacteria will be trapped inside. And recurrent دبتو. كان جين close دكين إلا أجر بطابي infection كمان control كرت. و تمشي معك granulation tissue كان هم healthyنا. heat بسكنا مابو. So then we can suture. Then we have septic thrombophlebitis in day 5 to 6. Septic thrombophlebitis, it involves venous inflammation and thrombus formation. It's usually accompanied by endometritis. كده زين ليرة key point تكتيا antibiotic كإيش ناكا. Fever will be prolonged يعني it's unresponsive to antibiotic. Then the diagnosis with CT and MRI, CT or MRI are studies of choice. Doppler CT scan and treatment with anticoagulants. We'll give heparin تونكا ليرة ثرومبسكا infected thrombosa. Antibiotic ناتاني invadica. So ليش feverka نارواتن. So there will be persistent infection. So heparin دديني هتا ثرومبسكا shrink بي و antibiotic بطاني إشي لسربكا. يعني كا anticoagulant دديني antibiotic راناغرين. anticoagulant دديني و antibiotic إش بردام دبين. أقدرش تمشاكين septic thrombophlebitis, emergency C-section, risk factor C-section after prolonged rupture membrane, finding a fever swing despite broad spectrum antibiotic. كمان أول key point تكيا with normal pelvic and physical examination management IV heparin IV طبعا for 7 to 10 days and keeping PT values at 1.5 to 2 times baseline. A complication كان هشيتيا لير باسكرديا if it invades the metritis and the parametritis may cause abscess, peritonitis, and eventually sepsis, septic thrombophlebitis. Then in day 7 to day 21 we have infectious mastitis, which may be due to the infant making trauma to the nipple and entry of the staph aureus into the breast and cause infection. So the signs are low-grade fever, chills, and indurated red painful segment of breast caused by staph aureus from the infant's oropharynx. So management كم treatment for the milk stasis. management milk stasis كستكين moist heat massage حتى دك تكان بكرينا fluid دينا مظهرك dehydration نبي rest and expression of milk and analgesia. Expression of milk يعني during breastfeeding بردوام كاران agree it's not harmful for the baby. And also antibiotics, the drug of choice is cephalosporin. If it's resistant to penicillin we may give erythromycin, clindamycin for 7 to 10 days. أجر her response نبو then we should do ultrasound تبزاين breast abscess man هي عنا. So أجا abscess man هبو drainage دكين. And yes, لير عينن lactation nipple trauma leading to nipple crackling and allow staph aureus to enter the breast ducts and lobes, and there will be fever with unilateral breast tenderness and erythema and edema. Breastfeeding should be continued, and if it's not respond to the antibiotics, we will do ultrasound to rule out abscess. And that was it. Thank you.